Good morning, everyone. It's a pleasure to meet you. My name is Hyungju Park, and I am a glaucoma specialist at Gangnam Tokyo Eye Clinic. Thank you for inviting me to the International Ophthalmology Conference. I wish this conference every success. Today, I would like to introduce a newly modified trabeculectomy, and I will compare its outcomes with the conventional method. I will explain the history of a national of trabeculectomy. Early trabeculectomy was a surgical procedure that drained aqueous humor through the entire layer of sclera. However, it carried a high risk of post-operative hypotony, suprachoroidal hemorrhage, and endophthalmitis. The current partial thickness sclera flap trabeculectomy was pioneered by Dr. John Cairns, and the flap is acted as a mechanical resistor, preventing excessive aqueous outflow. Consequently, the frequency of certain hypotony is decreased, and the predictability of surgical outcomes are improved. Currently, mitomycin and fibrorush are used to suppress fibroblast activity and preventing scarring of the filtrating flap. The trabeculectomy creates a guided fistula from the anterior chamber to the subconjunctiva and subtenon space. The sclera flap provides resistance to flow, allowing filtration through suture tension and postoperative suture lysis. Long-term success is dominated by wound healing biology at the conjunctiva-tenos interface. The episclera and subconjunctiva fibrosis leads to flap adhesion and subsequent re-elevation of intraocular pressure, causing the failure of trabeculectomy. The mechanism of intraocular pressure reduction in trabeculectomy is through aqueous outflow. The aqueous outflow rate in trabeculectomy is determined by the degree of flap opening and the size of the flap. And the level of intraocular pressure is determined by this aqueous outflow rate. The indications for the trabeculectomy are as follows: progressive glaucomatous optic neuropathy, despite maxillary tolerated medical therapy or laser therapy. Need for the very low target intraocular pressure, such as advanced primary open-angle glaucoma and progressive normal tension glaucoma. The conditions such as active ocular surface inflammation or conjunctival cicatrization are relative contraindications for trabeculectomy. Its complications are included the following: hypotony, shallow anterior chamber, choroidal detachment, maculopathy, flap leak, endophthalmitis, and cataract. I will explain the surgical method for conventional trabeculectomy. The surgically critical steps are as follows: carefully control breathing during conjunctival incision, create a single-layer sclera flap, and an antifibrotic agent such as mitomycin is soaked below the sclera flap and conjunctiva. Perform sclerostomy using a punch and scissors, and perform iridectomy to prevent the iris from obstructing the sclerostomy site. Suture the scalp flap with adequate aqueous flow and perform watertight suture on the conjunctiva. Next, I will explain the surgical method for newly modified trabeculectomy. From now, newly modified trabeculectomy will be referred to as NMT. In Japan, trabeculectomy with creation and removal of a deep scalp flap is considered the gold standard procedure, capable of reducing intraocular pressure to below 10 mm mercury without medication, even in normal tension glaucoma. This technique creates a deep scalp flap extending up to the level just above the choroid. During this process, the dissection is advanced anteriorly to expose the Schlemm's canal and extend to the descemet membrane. This technique creates an intrascleral drainage pathway, enabling lower sustained intraocular pressure. However, it requires high technical skill, and perforating the descemet membrane can complicate the procedure. Additionally, in this situation, vitamin C application is not possible, potentially worsening postoperative outcomes. NMT creates a deep scalp flap but dissects only up to the surgical limbus. Subsequently, a punch is used to remove the trabecular meshwork and Schlemm's canal. This technique is simpler and avoids complications like descemet membrane rupture. Consequently, it can sufficiently lower intraocular pressure while offering a safer procedure with fewer complications. I will explain the core operative steps of NMT. The major difference from conventional trabeculectomy is the creation of a deep scalp flap. The width of the deep scalp flap is 1.5 millimeter, including the central area. The depth extends up to the level just above the choroid, and it will extend to the surgical limbus. The following is a video of NMT surgery. Only the key steps are summarized. First, expose the sclera at the surgical site. Mark the sclera prep or trabeculectomy sclera mark. And create a superficial sclera flap using a gulp sclera knife to approximately half the thickness of the sclera. Sorry. Create a deep sclera prep using a 22.5 degree straight knife. After soaking and irrigating the mitomycin C, the deep sclera flap is removed using whisk scissors. Subsequently, the trabecular meshwork and Schlemm's canal are excised using a sclera punch. Perform peripheral iridectomy using Banach seizure. Suture the sclera flap using 10-0 S-cone suture. Begin suturing at the center of the sclera flap and exit the suture as laterally as possible, not through the entire thickness of sclera flap to secure it. I will explain the differences between conventional trabeculectomy and NMT. We observed the flap using fascia 2 anterior segment OCT. In conventional trabeculectomy, the aqueous outflow pathway within the flap is not observed in the right upper picture. There. In NMT, the aqueous outflow pathway within the flap is observed as a gap in the right pictures. The laser suture lysis process following trabeculectomy is performed in sequence 1 through 5 based on the degree of intraocular pressure. This is to prevent blood encapsulation by directing aqueous outflow toward the posterior portion of the filtration pouch, and it is performed between 2 and 3 weeks postoperatively. However, if performed after 4 weeks, or lesions develop, significantly reduce its effectiveness. The several types of lenses are used for laser suture lysis, including the Husky lens, Blumenthal lens, and Mandelkorn lens. Personally, I frequently use the Husky lens, but when the tennis capsule is thick and sutures are not visible with the Husky lens, I perform laser suture lysis using the Blumenthal lens. It is very useful lens. When performing laser suture lysis, it is important to start with the lowest possible laser power setting. Using excessively high energy can cause scarring or perforation of the conjunctiva flap. The following are the basic settings and lenses for the laser suture lysis. In my case, I use a spot size of 50 micrometers, a pulse duration of 50 to 100 milliseconds, and a power of 650 to 850 milliwatts. When performing laser suture lysis, if the suture is cut in the middle, the ends of the suture thread may later penetrate the conjunctiva and become exposed. In my case, I cut the suture as close as possible to both ends to avoid complications where the suture penetrates the conjunctiva. Now, I will report the surgical outcomes of conventional trabeculectomy and NMT performed at my own clinic from June to December 2025. First, examining the preoperative demographic data of both groups reveals no statistically significant differences in age, gender, visual acuity, intraocular pressure, or the number of preoperative glaucoma medications between the two groups. Therefore, it can be concluded that the two groups are comparable in terms of conditions. The complete success was defined as maintaining intraocular pressure below 15 millimeter mercury without glaucoma medication. The other ratio for NMT was greater than 1 at all time points. Therefore, this indicates that numerically NMT consistently has a higher probability of success than conventional trabeculectomy. Particularly at the 6 months, the conditional odds ratio is reached its highest value at 2.97. This indicates that NMT has nearly 3 times the success probability compared to conventional technology, suggesting that the effectiveness of NMT is most pronounced during the midterm stabilization phase following surgery. This Kaplan-Meier curve shows the complete success probability compared to the 81.3% success rate in the conventional trabeculectomy group at 6 months post-operatively. The NMT group maintained a 91.7% success rate, consistently demonstrating superior outcomes. There are no difference in intraocular pressure between the two groups at 1 month post-operatively, but at 3 and 6 months post-operatively, intraocular pressure was statistically and significantly lower in the NMT group. The NMT group has been maintaining very low intraocular pressure below 10 mm mercury stably. There was no difference in visual acuity between the two groups at 6 months post-operatively. We report on the post-operative medication requirements at 1 and 3 months post-operatively. Neither group of patients required glaucoma eye drops. 6 months post-operatively, 18.7% of the conventional trabeculectomy group and 8.3% of the NMT group required one type of glaucoma medication. As for early post-operative complications, shallow anterior chamber and choroidal detachment occurred in 3 cases in each group. However, all cases resolved spontaneously during follow-up with conservative medical treatment. Regarding late complications, the conjunctiva trabeculectomy group presented with intraocular pressure elevation in 6 eyes and flap scarring in 5 eyes. Although these findings did not reach statistical significance, compared to the NMT group, the 0% incidence rate in the NMT clinically support its safety profile. To conclude, the data clearly demonstrate that NMT provides superior outcomes in 4 key areas. First, pressure control. MNT achieved a significantly lower median intraocular pressure of 8 mm mercury, making it an ideal solution for the interactive normal tension glaucoma patients. Second, success rate. We saw a higher medication-free success rate of 91.7% at 6 months. Third, safety. The safety profile was exemplary with 0 instance of serious complications such as flap scarring or intraocular pressure elevation. Finally, clinical impact. This technique not only reduced the patient's medication burden, but also offers a more reproducible, simplified surgical approach. While the results are promising, we must acknowledge a few limitations of this study. First, sample size. The MNT group was relatively small with 27 eyes compared to lying for in the conventional trabeculectomy group. This may limit the statistical power to detect real complications. Second, follow-up period. Our current data tracks outcomes up to 6 months. Further longitudinal monitoring is needed to confirm the long-term stability of the filtration plaque. Third, study design. This was a retrospective single-center study conducted at Gangnam Tokyo Eye Clinic. The result may reflect the high proficiency of a specific surgeon, so multi-center randomized controlled trials are required for broader validation. Finally, selection bias, as this was not a randomized trial, baseline differences other than intraocular pressure might have influenced the choice of surgical technique. In summary, MMT provides a superior, more sustained intraocular pressure lowering effect with fewer postoperative complications, establishing it as a highly effective and safe surgical solution for managing medically intractable open-angle glaucoma, especially normal tension glaucoma. This concludes my presentation on the NNT. Thank you for your kind attention.